Hello everyone, welcome back to the channel. Today we're going to be learning about heart failure. So by definition, heart failure is the inability of the heart to pump sufficient oxygenated blood in the metabolizing tissues despite inadequate filling pressure. And this can be due to numerous reasons such as wall stress, dilation or ventricular remodeling within the myocardium, which leads to the myocardium failing to pump the blood sufficiently. Now, there are many different subtypes and classifications of heart failure. So the first being left versus right-sided heart failure. Left-sided heart failure, L for lungs, is related to the lungs. So it can lead to pulmonary congestion, which leads to the patient experiencing symptoms of exertional dyspnea, orthopnea, which means waking up at night feeling breathless. They may need to prop themselves up upon a pillow to help them to breathe. Systemic hyperperfusion, fatigue, and postural hypertension. And our right-sided heart failure is heart failure that relates to the rest of the body, R for rest of the body, and it can lead to systemic congestion, which can present as symptoms of cardiac cachexia, abdominal distension, peripheral, and pitting edema. Other types of heart failure include systolic versus diastolic heart failure. Systolic heart failure is when the heart is normally able to, the ventricles are able to fill properly, but there is an impairment in the contraction of the ventricles. And this means that even though the ventricles fill up well, the heart isn't able to pump the blood sufficiently out of the ventricles because the myocardial contraction during systole is impaired. Essentially, there's a reduced ejection fraction. Common causes of systolic heart failure may include ischemic heart disease, dilated cardiomyopathy, myocarditis, infiltration, so things like hemochromatosis and sarcoidosis. Now, in comparison, in diastolic heart failure, the diastolic function is impaired. So that means the ability of the ventricles to relax and fill with blood is impaired, even though the heart is still able to pump and contract well because it doesn't. There's reduced diastolic filling. There is a preserved ejection fraction. Now, common causes of diastolic heart failure includes uncontrolled chronic hypertension, which can lead to significant left ventricular hypertrophy, which reduces the filling of the left ventricle, hypertrophic cardiomyopathy, cardiac tamponade, and constrictive pericarditis. Other ways of classifying heart failure include acute or chronic. Acute is when it's a very new onset heart failure, and chronic is when there's been going on for a long time and progressing more slowly and developing over the years. Now, chronic is further subdivided into systolic and diastolic heart failure, which we explained previously. There's also high output versus low output heart failure. In high output, there is essentially an increased metabolic demand. So that can be due to a number of reasons, such as anemia, Paget's disease, pregnancy, thyrotoxicosis, thiamine deficiency, and these essentially increase the metabolic need of the heart, hence leading to high output heart failure. And in low output heart failure is when there's heart failure, when the heart's output is reduced due to a primary problem of the heart, so the heart is unable to meet the body's needs. Common symptoms of heart failure include breathlessness due to a reduced supply of oxygen to the tissues, a reduced exercise tolerance, which reduce metabolism at the cells, fatigue, as well as ankle swelling or peripheral edema. And signs which may be observed by the patient include cyanosis, tachycardia, a raised JVP, orthopnea, waking up at night feeling breathless, peripheral edema, displaced apex beats, and bilateral crackles. Now, to investigate heart failure further, we can split this up into bedside, bloods, and imaging. In terms of bedsides, we want to do an ECG. We want to look for signs of hypertrophy, any ischemic changes, signs of left bundle branch block, and arrhythmias. And then in terms of bloods, we want to do their full blood count using these LFTs, thyroid function tests, glucose, lipidemia. A really specific test that we want to look out for includes the NT-proBNP. Now, in terms of the NT-proBNP, if its great levels is greater than 2000 NGL, that means that we will need to urgently refer the patient for specialist review and for them to have a transthoracic echocardiogram at least within 2 weeks. If it's moderate levels, so if it's between 400 to 2000 ng per liter, then we want to refer them for specialist assessment and for assessment with a transthoracic echocardiogram within the next 6 weeks. And if they have slight raised in NT-proBNP, so for example less than 400 nanograms per liter, then that means that a diagnosis of heart failure is quite unlikely. We can also use imaging. So upon imaging, we can use an echocardiogram to detect if there's reduced ejection fracture, which is a common sign of heart failure. We can also do a chest x-ray, and we're looking for the signs of A, B, C, D, E. A leading to meaning alveolar edema, which is a kind of bat wing appearance on the chest x-ray. You can see on the image on the right. B standing for Kirby B lines, which is an interstitial edema. C for cardiomegaly, so the heart being enlarged. This can be due to a buildup of fluid around the heart. D for dilated prominent upper lobe vessels. And E for pleural effusion. There may be also a reduction in the sharpness of the costophrenic angles at the diaphragm. And these kind of findings on a chest x-ray using the mnemonic ABCDE can indicate heart failure. There's a kind of classification system called the New York Heart Assessment Classification System, which we can use to classify the severity of heart failure. So number one being if they have no problems, no limitation of their physical activity, they do not get breathless, fatigued, or palpitations upon doing normal activities. We can classify this as the New York Heart Classification of 1. For 2, there may be slight limitations of physical activity, so they may be comfortable at rest, but ordinary activities such as going up and down the stairs, turning on the TV, any kind of activities that you do day to day, going to the grocery store, can lead to them feeling quite breathless and fatigued and with palpitations. In classification 3, any kind of physical activity is going to lead to them feeling breathless or fatigued or palpitations. Although they may be quite comfortable at rest, they're less able to do ordinary physical activity. And in terms of class 4, they're unable to carry out any physical activity without visible discomfort. There may be symptoms of heart failure even at rest, and any physical activity that is taken can compromise their comfort and lead to symptoms of heart failure. Other differentials that we want to be looking out for include COPD, because it presents in a very similar way with dyspnea and significant respiratory distress such as fatigue. Differences with heart failure include that in heart failure, the shortness of breath is typically worse when you're lying flat, or orthopnea, such as when you're lying in bed at night. And it can also be accompanied by paroxysmal nocturnal dyspnea, so waking up at night feeling breathless, and peripheral edema, which is not the case with COPD, because COPD tends to be worse on exertion and is more likely to be accompanied by symptoms such as a productive cough and a smoking history. Other potential differentials include acute respiratory failure, again, very similar symptoms such as shortness of breath, tachypnea, respiratory distress. Both of them lead to an accumulation of fluid in the lungs, an impaired gaseous exchange, which can lead to hypoxemia. However, the difference is that with heart failure, you can get a raised pressure in the pulmonary capillaries, whereas with acute respiratory distress syndrome, it's usually more due to an increased pulmonary capillary that's secondary to the large insult. For example, you may have before to the ARDS had pneumonia, aspiration, or trauma. And yeah. So those are some other potential differentials. Now, in terms of management, it's different based on whether the heart failure is acute or chronic. So with acute heart failure, we want to do the steps in the mnemonic of LMNOP, which stands for position. So sit the patient upright, because as we know, lying flat can lead to orthopnea in patients with heart failure. We want to give them a loop diuretic such as furosemide to help to relieve and release some of the fluid that's been building up around the heart. Give them high flow oxygen to aid in breathing. We also want to start a nitrate infusion. And this will help to kind of relax the heart. And we can also consider CPAP. And we need to monitor the patient if we're treating acute heart failure. This can be done using a news chart to see their OBS, by repeating chest x-rays, taking daily weights, and switching, if they're having any symptoms, switching the furosemide from IV to PO, and also checking their ejection fraction using the echocardiogram. Now, in terms of chronic management, first we want to give them an ACE inhibitor or a beta blocker. So the most commonly used drugs will be bisoprolol, carvedilol, nebivolol, and you want to start it one at a time. And then we want to give the kind of really classic drugs, so a aldosterone antagonist such as spironolactone, angiotensin II receptor blockers such as losartan, candesartan, and if they're Afro-Caribbean, then you want to prioritize giving the patient hydralazine and nitrates, and combine that with a loop diuretic such as furosemide, which will help to provide symptomatic relief by reducing some of that edema and that fluid overload. And then afterwards, if we've done that, we want to give them digoxin, which will provide symptomatic relief, especially if they've got atrial fibrillation. Digoxin can help with rhythm control. And then we can give them ivabradine, especially if the patient is already on, before we give ivabradine, we want to make sure the patient already is on an ACE inhibitor, beta blocker, and aldosterone antagonist, and the heart rate is over 75, and they've got a reduced ejection fraction of less than 35%. And then we can consider more invasive therapy, such as cardio resynchronization therapy, especially if they've got a prolonged QRS complex. And in terms of chronic heart failure, we always want to offer the patient an annual influenza vaccine and a one-off pneumococcal vaccine, unless they've got things like CKD. And we also want to treat any underlying conditions such as arrhythmias and valve disease, and try to avoid anything that can exacerbate or worsen the heart failure, such as anything that would increase metabolic demand on the heart, such as anemia, thyroid dysfunctions, NSAIDs, verapamil, things like that. And just to note, some drugs that can actually provide mortality benefit in patients with heart failure are listed below. You can remember it with the mnemonic BASH, so B for bisoprolol, A for ACE inhibitor, S for spironolactone, and D for hydralazine with nitrates, which we want to prioritize in patients who are of Afro-Caribbean descent. And in terms of furosemide, it can provide symptomatic relief by helping to get rid of edema, but it's not going to improve the mortality rate or provide any mortality benefit within patients with heart failure. Thank you for listening. This was quite a lot, very heavy topic. So make sure you go over all the guidelines, do as many questions as you can. If you have any questions, then please do let me know in the comment section. Thank you for watching.